Indirect restorations normally take 2 or 3 visits, depending on the teeth, the location, the materials used, or any combination of all of these. As before, the needed basic setup and anesthetic materials are gathered. While the anesthetic is taking place, and if a porcelain crown is planned, a shade guide is used to select a shade that matches the adjacent teeth. At this point, a snap impression may be made and set aside, using wax or alginate, into which a temporary can later be developed after the tooth is reduced for the crown inlay or onlay. The film on prosthodontics explains in greater detail how to make these intraoral impressions. Using a high-speed handpiece, and probably diamond burrs, the dentist shapes the tooth for the restoration. Surfaces to be replaced with porcelain must be reduced by as much as 2 millimeters. Surfaces to be covered with gold, as little as a half a millimeter. Needless to say, a lot of water coolant spray and suction is needed to help keep everything cool and clear during the enamel reduction. As we've said before, all reusable burrs must be sterilized between patients. They are best kept on a burr block during treatment. Any decay remaining in a tooth is removed with a slow-speed handpiece and round burrs, or by hand with a spoon excavator. Large irregularities in a tooth prepared for a crown are corrected with a filler material like glass ionomer, which has great adhesive qualities and also contains fluoride. The goal is to have a smooth and properly shaped tooth so that the crown can be properly seated. Using a mouth mirror, the doctor determines that all of the walls of the preparation are shaped properly, allowing the crown or inlay to seat completely on the tooth. Notice how the sides of the tooth can be seen diverging, and the tooth gets wider towards its base. This assures that the crown will fit properly. Since the gums are very delicate, we can protect them by moving them back from the edges of the tooth where we're working. Special cotton cord is gently placed around the tooth using a special dull-bladed instrument. This process is almost always the dentist's responsibility by law, depending on your state. Various chemicals can also be used to pre-moisten the cord and improve the retraction. The gums overlying the cord then just temporarily shrink away from the treatment area. With the gums temporarily pulled back, a rubber-like paste or putty is mixed. It's then placed into an impression tray. This tray covers just the area of the mouth where one tooth is being treated. Generally, the more extensive the care, the larger the tray and the impression area. Just before placing the tray over the prepared tooth, a special fine-tipped syringe injects a thinner but similar putty around the tooth, capturing the finer details of the prepared tooth. This impression material is called a wash. If the impression is acceptable, capturing the details of the tooth without impregnated bubbles, a bite registration is made with another type of putty or using wax. Then the temporary can be created. There are several ways that a temporary can be made. The method shown here involves lightly loading the void of the treatment tooth within the wax or alginate impression made at the beginning of the appointment with an acrylic temporary material, and then placing this impression back onto the tooth. The soft acrylic forms a temporary crown nearly identical to the original tooth within the impression. Just before it sets, but while still rubbery, the impression is removed and checked for fullness and accuracy. If the temporary doesn't cover the tooth completely, the tooth is likely to become sensitive and to trap food. If all's well, the temporary is removed from the impression and trimmed to properly cover all exposed tooth surfaces, while leaving room between the teeth for the gums to rebound into when the retraction cord is removed. Here, the assistant checks the bite using articulating forceps and paper. She can then adjust the temporary crown and refine its shape before giving it a final polish. Finally, the polished temporary is cemented using a temporary paste like Temp Bond brand. Some doctors like to use other pastes and liners not necessarily intended for cementing temporaries. These are good opportunities to learn from the doctor's experience. Excess cement, which can cause gum irritation over time, is removed from the temporary's edges with an explorer and knotted floss. Finally, the occlusion is evaluated again with articulating paper and forceps, and again adjusted if it's needed. Steel temporary crowns can also be used, as well as preformed plastic polycarbonate ones. The metal temporaries are trimmed with scissors, shaped with special pliers, and relined with acrylic. The bite is then checked and adjusted if needed. Finally, the temporary crown is polished and cemented in the same manner described before. We can't emphasize enough how important it is that retraction cord be removed. If it's accidentally left in until the patient returns, it can cause inflammation, infection. It can even cause a potentially serious periodontal defect. Following the procedure, the patient should be told how to care for the temporary and then be reappointed for the delivery of the permanent crown, inlay, or onlay. At the patient's appointment for the restoration cementation, again the basic setup is available. However, many doctors find that they can cement the crown, inlay, or onlay without numbing the patient's tooth. Have the anesthetic materials available anyway, though, since many patients object strongly to the cold water rinses and the blasts of air that are needed during cementation. The temporary is removed using a large spoon excavator or towel forceps as shown. The residual cement is carefully cleaned off with a small spoon excavator or explorer, and the tooth is washed and dried. The dentist then tries the restoration in. If it's being placed in the back, a special wax-tipped wooden stick, like the one shown used here, is helpful for carrying it safely into place. Notice that the 4x4-inch gauze throat pack, lightly being placed behind the treatment area, can function to catch the crown if it becomes loose during the try-in. The patient may be asked to gently bite down onto a cotton roll or a large special wooden stick centered over the restoration to help seat it. The doctor then uses an explorer to feel for the fit of the crown's edges. If it's seated all the way down properly, the bite is then checked with the articulating forceps and paper and adjusted as needed, either in the mouth or outside with the high-speed or slow-speed handpiece, according to the doctor's preference and the type of restoration. If the restoration needs adjusting, its finish is recreated before cementation. Gold crowns need to be polished using special pastes. Porcelain restorations must be reglazed, or at the very least polished with their own special pastes, since rough porcelain abrades the opposing teeth that it touches. Finally, after the tooth is cleaned and dried, the restoration is loaded with a special permanent cement that's mixed on a glass slab, if it's a type that gets hot, or on a coated paper pad. Basically, 4 different types of permanent cements are used. The zinc phosphate, becoming less popular, gets hot during mixing, so it's mixed on a glass slab. It can take up to 20 minutes to set. Glass ionomer actually bonds to the teeth, is extremely strong, and even releases fluoride over time. Also mix it on a glass slab. The zinc oxide eugenol, or ZOE, and the polycarboxylate cements are mixed on coated paper pads. They mix quickly, and they also set quickly. After the underside of the crown is painted with a thin film of the cement, the dentist quickly but carefully sets the crown in place, with the patient then biting down on a cotton roll lying over it, or the doctor may press it downward and hold it with his fingers. Just as the temporary cement was cleaned up, the excess permanent cement is removed from the crown's edges with an explorer and the knotted floss. This is most easily done when the cement is just about to be fully set. However, be careful not to disturb the restoration. The array of procedures that your practice can offer helps improve your patient's health, and some may also help improve their smiles, which is even more important to some patients. These include cosmetic treatments like bleaching teeth and even porcelain veneers. The porcelain veneers are like false fingernails. They are fabricated in much the same sequence as crowns. In the end, they're placed using the procedures described in composite bonding, with acid etching and light curing. The entire technique is as delicate as the veneers themselves. Bleaching processes use either daily in-home patient-applied materials, usually a mild acid and a mouthpiece, or a more involved in-office procedure. The stronger chemicals used with some in-office bleaching techniques, along with heat, light curing, or both, can result in more rapid results. A rubber dam is often needed to protect the patient's mouth from injury. In dentistry, restorative care almost always sends a patient from your office healed of disease. It's a claim that even medicine can't always make. With the additional elective cosmetic procedures, dentistry is moving toward improving patients' self-esteem as well as their oral health. Restorative dentistry is a vibrant, dynamic element of patient care. Some procedures go predictably. Others test your patience and your treatment skills. In essence, it's this ever-changing element that helps keep the practice of dentistry somewhat exciting. When things seem to be going bad for you, remember your obligation to your patient. By making sure that things go well for him always, your days helping deliver restorative dentistry remain satisfying. And if you always imagine that the patient in your care is either a friend or a member of your family, you can never go wrong.